welcome. Hopefully you'll be able to take a nugget or two out of this talk that's helpful and relatable to maybe your own health or family members. I moved here in 2013. My wife and we have 3 boys. Oldest is 7. I went to the University of Minnesota for most of my college education, pharmacy school and med school, and then some undergraduate. And then I did a 5-year residency at Ohio State in Columbus in urology, and graduated in 13 and then came here, and I've been here. I'll be starting my 4th year now. So we love it, and really look forward to spending probably my whole career here. So anyways, I'm going to go ahead and get started. So I'm going to talk about prostate cancer prevalence, some data, and then really when you think about PSAs, prostate cancer, think about it in 3 separate phases. There's screening, so it's patients who haven't been diagnosed but wondering what the risks and benefits of that are for screening. And then there's diagnosis of potential cancer that is located in the prostate and only the prostate, and that carries along with it multiple treatment options that I will get into. And then finally there's prostate cancer that is spread, and that is another completely different approach and treatment option. So the prostate gland, it wraps around the urethra almost like a donut. It makes about 1/3 of the fluid with ejaculation, and it is also a muscle, and it causes the fluid to exit the urethra. Causes problems with urination, as we all know, and it also has the potential for causing cancer. This is a picture. The yellow on the right, that's the prostate gland itself, and the tube, you'll see there's a T intersection. That's the area where the seminal fluid is entering the urethra, and then the urine goes from the bladder straight down through the urethra and then out the end of the penis. Statistically, it's the most common cancer in men. I put red boxes around other urologic cancers that I see patients for, bladder cancer as well as kidney and upper tract urothelial cancer. In terms of death from cancer, it's the number 2 cause of cancer, death, and it kind of vacillates between number 2 and number 3 depending on the year. It flips back and forth with colon cancer. So again, about 250,000 patients per year are diagnosed. It's the 2nd most common cause of cancer death. And the troubling thing, or the difficult thing, is who should be diagnosed. Most patients who live into their 80s and 90s are going to develop prostate cancer. And the trick is to identify the ones that need to be identified. And I'll talk about that in much more detail later on. So most commonly, it is a slow-growing cancer. Not always, but commonly. It's most commonly detected with a blood test, a PSA test. That's a protein that the prostate secretes. The value indicates risk of cancer. It doesn't tell you have it or you don't. Extreme ends of the range are very reliable. The middle is not as reliable, and that's also where some of the trouble comes into play. Back in the 70s, we diagnosed patients with prostate cancer when we didn't have PSA. It was primarily with locally advanced disease. In other words, the cancer has really started to spread outside the prostate, and that's when you have an abnormal exam. Or a patient comes in with symptoms, weight loss, bone pain, things like that, cancer symptoms of other areas of the body. And that's obviously not an ideal time to diagnose it. Cure is not possible at that point. And this is just a graph that depicts a different way to think about cancers, more from a physician perspective or medical perspective. Not all cancers can be effectively screened. And there are many reasons for that, but this graph shows the impact of the rate of growth of the cancer in time. So, for instance, let's look at tumor D. This is a cancer that a patient can develop and then will just take off right away, grow very quickly, spread, and then kill the patient. That type of a cancer is very difficult to screen for because the window that you'd have to identify the patient is so narrow. Think of like an aggressive pancreatic cancer. That would be an example. On the other end of the spectrum, we've got tumor A, which is an incredibly slow-growing cancer. It stays microscopic in the gland itself. It never spreads beyond the gland, and it never spreads to any other organs. That would be another type of cancer that you probably wouldn't actually want to identify that one. You'd want to ignore if you could. Tumor B and C are the ideal time growth pattern where identifying it is both reasonable and provides a value and benefit to the patient. Not all cancers are Bs and Cs. Some are As, and some, unfortunately, are Ds. Even some prostate cancers are D. So some common comments that I get from the clinic, does PSA work anymore? Are we even getting it? Should I even get one? That type of thing. That's what I'm going to try to address in the next few slides. I'm not going to give you an answer, but I'm at least going to give you the controversy, the data behind it, and as you'll see with the recommendations of the major organizations in the country, hopefully provide some education, and that's really the point, is to make the decision for yourself, because there's risks and benefits, both getting it and risks and benefits of not getting it. So the big controversy was in 2011. So the United States Preventive Services Task Force, the USPSTF, it's a government-based organization, in 2011 came out and said PSAs should not be acquired on any patient at any time. It's not a good test. It should never be collected. That's what prompted all of the kind of controversy you see in the news, on the internet, wherever. I see it in clinic. So there's 3 trials, 2 European trials and a US trial that evaluated the effectiveness of PSA screening. And I'm going to go over each trial. I'm not going to get into the bushes with you on the study and talk about all the data, but I'm just going to kind of highlight the key points. So the names of the trials are PLCO, that's the American trial. That was a conglomerate of looking at not only prostate, but lung, colorectal, and ovarian. The ERSPC is the big European study. And then Goldberg, I'm not going to spend too much time talking about that. The results of Goldberg were actually added to the European study, so it's almost a subset of it. So there's really, think about it as just 2 main trials, one in the United States, one in Europe. Who did the trial better? That's the question. So this is the American study. It's the PLCO study. So about 80,000 patients between 55 and 74. And the key points are, prior to the study, 70% of the patients had already been screened with a PSA. There were 2 groups. There was one group that was getting a PSA every year, and there was another group that underwent usual care. This was occurring in the 90s and early aughts in the United States. Usual care at that time was an annual PSA, was getting a blood test once a year. So basically you had 2 groups. You had a group that was getting a PSA every year, and then you had a group that was mostly getting a PSA every year. Guess what they found? No difference. Big surprise. Not really, but the trial got more credit than it really should have. They didn't find a difference in death benefit, and these are 2 different conclusions. So this was the 10-year follow-up, and then they did an update at 13 years. And I put this up because it's actually pretty interesting. They changed the wording very dramatically in the conclusion, and that was due to a lot of the pressure that the medical community gave the authorship, in that, if you read here, there was no evidence of mortality benefit or death benefit for organized annual screening, which was the one group, organized annual screening, compared to opportunistic screening, which forms part of usual care. And again, most of those patients were getting PSAs, so it's really difficult to show a difference one way or the other when you have 2 groups that are almost identical. So it was not a trial of screening versus no screening, and this is a kind of a number soup sentence that gets pretty confusing, but the bottom line is it's just saying it's a bad study. Unfortunately, it shouldn't even be, in my opinion, it should not have been published. It's that poor, because it misleads a lot of folks. The next study was the European study, which was done much, much better. There was only a 15% contamination rate. In other words, the group that was not being screened, only 15% ended up being screened. So you had 85% of that group actually didn't have any PSAs, and that allows you to actually compare the 2 groups of PSA versus no PSA. They were doing PSAs every 4 years. The age range was fairly similar, and it was a little over double the population of patients. And they found a 20% reduction in relative risk for death. So this is the data from that trial, and it shows the 2 graphs. This is the relative risk of death in time from prostate cancer, specifically in time. As the 2 curves diverge, that's where it's showing you the difference, that the screening group relative risk of death for prostate cancer is lower than the control group. The controversy with this study comes in, it's not so much controversy, but it's the reality, and that is the number needed to diagnose. We needed to diagnose 36 prostate cancers to prevent one death. That's a lot of medical treatments, a lot of procedures, a lot of side effects, a lot of cost, emotional, financial, to everybody, families, patients, the system. That's not completely out of range with a lot of other cancers, breast cancer, colon cancer. And the number needed to invite to prevent one death, invite to screening, was almost 1,000 patients. So this is getting back to the USPSTF recommendation. They gave it a grade D. Again, that meant don't collect PSAs for patients. They said nothing about high-risk patients. They said nothing about family history. What if, my father was diagnosed when he was 52, died when he was 59. His brother died when he was 62. Some very high-risk family. No mention about PSAs with that group. African Americans are much more likely to develop deadly prostate cancer than Caucasians, and there's no mention about that stratification either. The USPSTF was comprised, this is the authorship from the paper, and the total number of prostate papers that they had published prior to this study, 3 out of the whole group for their entire career. So it wasn't a group of experts, on prostate cancer. This is a summary of the screening guidelines, depending on whether you look at the NCCN, which is the National Comprehensive Cancer Network, the American Cancer Society, or the American Urologic Association. There's a lot of words up there, but the bottom line is they all have themes, and the theme is, screen between 55 and 70, start earlier if there's higher risk, family history, African American, that type of thing. Don't screen after 70 or 75, depending on which guideline you read. The reason they give the age range is because that's where the data comes from. That was the inclusion criteria. So if you look at the European study, it was for patients 50 to 69, 55 to 69. That mirrors the ages that they put in the guidelines. This slide depicts 1930 all the way to today, and it's risk of death from specific cancers. Like yellow is stomach. We don't know why that's plummeted. It used to be the #1 cause of cancer death back in the 1930s. It's plummeted. There's a lot of theories. I'm not a stomach cancer expert, but H. pylori is a thought. The types of foods we eat is a thought. But anyways, the point that I'm trying to get to is prostate cancer. So prostate cancer's tumbled quite a bit since the 1990s, and that's when PSA screening was started. Lung cancer has dropped with the drop in smoking. Colon cancer has dropped with the use of colonoscopies. Liver has been fairly flat. Pancreas is fairly flat. So I didn't end with an answer on whether you should be screened, but I just wanted to show you this is the controversy. The thing I like to tell patients in clinic to further confuse them is the #1 group of patients who most consistently and regularly and routinely undergo PSA screening are VA patients. And if you think about that, that's a government-based hospital. The USPSTF is a government-based group, so there's not even agreement there. It is a controversial issue, and there are definitely risks and benefits on both sides. I do think that it's clear, though, that we have data that shows that it does save lives. This is diagnosing, so this is a prostate biopsy. It's an office-based procedure. This is basically the procedure that you see your physician, you have an elevated PSA, you have a discussion about the next step, and the next step would be a biopsy, and that would be diagnosing prostate cancer or normal. Again, it's a decision that is personalized based on the patient, the age, PSA value, other illnesses that they have, heart trouble, lung trouble, something like that can affect your decision. The goals of the patient are obviously very important as well. Once a patient's diagnosed with prostate cancer, there's really 4 main categories of treatment. The first is called watchful waiting, and that is essentially not doing any ongoing testing, not even checking PSA. You've identified the cancer. Let's say the patient's 85 and they have heart trouble. You say, you know what, come back and see me if you have any trouble. If you start having weight loss, bone pain, it's not a very common approach these days. Active surveillance is much more common. Active surveillance is saying, look, every 6 months we're going to get a PSA. We're going to see if there's any signs that there's progression of the cancer. We'll probably do a repeat biopsy at something like 1 year. There's surgery, removal of the prostate, and there's radiation, and that comes in 2 different forms. There's external beam radiation, where you basically go in 40 treatments over 8 weeks and receive the treatment in about 5 minutes. And then there's seeds, which is brachytherapy. Those are placement of little radioactive pellets in the prostate itself. So again, watchful waiting, there's no active treatment. There's not a lot of testing. From a patient perspective, it's pretty easy. You don't have to come in and have any testing done. The goal is to really manage the symptoms if they develop, and many times they won't. For active surveillance, this is where we're keeping an eye on it, and this is really the type of plan for low-risk cancers, not high-risk cancers. The benefits are you're going to avoid the side effects of treatment, of surgery and radiation. The value, that's dependent on each patient. Again, getting back to the side effects of surgery and radiation, things like erectile dysfunction. That's valued differently for each person, each patient. So the benefits of this for one patient, they may say, you know, that there's not a lot of value there. The big risk of the cancer progressing and not being able to stay on top of it, I want to have it treated. Where another patient's going to say, you know, being able to have an erection is one of the most important things in my life. So absolutely, I want to go down this pathway. With active surveillance, you can always switch over to surgery or radiation if there's any signs of progression of the cancer, with either the PSA suddenly rising, a repeat biopsy showing worse cancer. Many patients would say, if I'm on active surveillance for a few years and then switch over, that's still a win. I still ended up with 3 or 4 years of minimal side effect, avoiding side effects from treatment. Surgery is removing the gland itself. It's between the base of the penis and the bladder. The urethra has to be sewn back to the bladder. That's a surgery that I usually send patients to either Duluth or the cities, Mayo, usually one of those 3 options. Again, the main side effects are leakage and erections. Commonly done robotically now. That's what it looks like when those little arms that are you're using with the use of the robot. Radiation, there's 2 main types. There's the external beam and brachytherapy, or the seeds. This is a patient who's undergone brachytherapy. The prostate is right in the center, and the X-ray is showing the pellets, the brachytherapy seeds, the pellets that have been placed. It's a one-time procedure. So that's the big decision that I talk to patients about. Active surveillance should be a 3rd arrow, but not all patients have the option of active surveillance if they have an intermediate or high-risk cancer. I mean, they can tell me that's what they're going to do, but I don't recommend it, you know, when it's a higher risk cancer. So stratifying the patients based on risk is really important. So this is a kind of like the 3rd chapter of prostate cancer. Now, we're not screening for it. We're not trying to cure it locally at the prostate level. It's now spread, and we're trying to manage it. So there's no cure for patients at this point, but there are a lot of treatments to help manage it. Patients can live many, many years with prostate cancer that has spread. The main treatment is medications that drop the testosterone down to almost 0, kind of like I call it menopause in clinic. Like menopause, the wives usually smile because they say, finally you get to experience what I had to live through. But you know, hot flashes, decreased energy, moodiness, weakening of the bones, those are all the main side effects. There are a lot of very expensive new medications that have come out that are kind of like hormone therapy plus. So they affect the hormone axis in the body, but they do it through new ways and shut the testosterone down even more. And that's Zytiga and Xtandi. They don't make the names any easier to pronounce, that's for sure. IV radiotherapy, so radium-223, that's an IV administered once a month for 6 months. And what it does is it treats bone lesions. If a patient has bone-only lesions, again, it doesn't cure it, but it can help slow down the growth. And finally, there's another completely unique drug called Sipuleucel T. That treatment is very unique. A patient's blood is drawn. The white cells are removed from the blood. The white cells are then exposed to prostate cancer and basically train them just like you would a hunting dog. And then you administer the cells back to the patient. And the cells then will go in and attack the prostate cancer. Sartell and I think Mayo might also have an administration center, but I know Sartell does in Minneapolis. But this is there's a very narrow indication for this. It has to be a younger patient who's very healthy. You know, they have to have a very healthy immune system. If the immune system isn't very healthy, it's not going to respond the way it needs to. Chemotherapy is after all of those therapies have failed. Obviously, there's a lot of side effects with chemotherapy, and there's no exception here. We don't know the order of the therapies. Most of the ones I mentioned are all pretty brand new. They've all come out in the last 5 years or so. And when they're that new, we certainly haven't compared them in order, figure out which ones are better early on, which ones are better later on, which ones should we combine. Those types of things we don't know yet. We do know they're expensive, though. So the bottom line, you know, prostate cancer is very common. It can be slow-growing or fast-growing. It's most commonly slow-growing, but not always. Prostate cancer screening does save lives. Cure is possible with surgery or radiation. And once it's spread, it's not curable, but it's very manageable. That's it.